Welcome to the Change Agents Learning in Action kickoff call for 2016. My name is Sarah Woolsey. I'm Medical Director with Health Insight. I'm based here in beautiful Utah, and we are excited to get started right on time this morning. Welcome to all of you who are on the phone. We hope that as many of you as possible are on the WebEx. We'll be engaging in some interaction there today. Like I said, I'm Medical Director here with Health Insight Utah. I'm also a trained family physician and practice in a low-income, underserved, federally qualified health center part-time. And I'm excited to continue the dialogue that we started back in October. Many of you may have been at the Change Agents kickoff in one of our states, Nevada, Oregon, Utah, or New Mexico. And we had our beginning dialogue there, and we're going to continue the conversation in 2016. My job today is to continue discussion on our organizational success in a changing healthcare environment. That means both quality and outcome improvement for our patients, to share organizational strategies for care for complex patients and those with chronic conditions, and then expand your network of community partners to improve your success. And I wanted to highlight much of what I'll talk about today. Health Insight can be a source of referral, of connection, or support for these programs. So I want to just really highlight, reach out to your Health Insight locally or to me. My web address will be available at the end of this talk if you have questions or want to connect about something we've talked about today. Like I mentioned, we're going to be chatting. Because there's a high volume of participants on the call, we're going to mostly interact by chat. So feel free to practice chatting. Be ready to answer a few questions. We'll also have some polls. And like I said, we'll get to as many of the questions as we can. If there's something that you have a question about, please directly email me using my email that we'll present at the end of the meeting. Also at the end, we'll be evaluating this session. Please stay on and do a brief survey if you can right at the end. Your chat box is in the right lower corner. So our first chat is going to be, please share something you're doing that's really working for your patients with chronic conditions. So no matter what setting you come from, if you're from home health or you're from a skilled facility, you're from an outpatient setting, maybe you're a care manager, go ahead and share something you're doing that's really working well. And let's see what that is. All right, we're seeing some folks starting to add in the chat. Lots of people chatting. I can't see them though. Okay, so we have engagement of family members or significant others in the care process. That's really great. So sending scales home from the hospital for CHF patients. I like that from Becky. Let's see if we can get a couple of more before I move on. Follow-up appointments prior to discharge. Great living well programs. We will talk about that a little bit today. Care conferences. Okay, I really like this home strategy, home care patient experience, resiliency. So Mike Silver, you'll note our guru from the October event. Okay, and monitoring with patient education. Okay, all right, very much appreciate that feedback. So thank you for sharing and practicing. And again, I can kind of get a flavor of what your interests are, what your capacities are. So for our time today, we're going to talk about learning ways to identify patients with complex needs in your setting, assess your environment for support for your patients with complex needs, and then be introduced to low-cost practical strategies for supporting patients with complex needs. And we'll touch on being reimbursed for the supportive care. As we know, we're in a changing payment environment, and we want to give you some opportunities for now in the short term that can benefit you as you develop your strategies. Now we're going to just do a quick poll so I can get a sense of what settings, where you're coming from. So go ahead and launch our poll. Please answer, what healthcare setting do you work in most of the time? So we can kind of get a sense of who's here. All right, so outpatient office, close to my heart. You guys are winning. We have a smattering of hospital, skilled nursing facility folks, okay, a lot of other. We clearly didn't get your category there. MCO, home health, home setting, great. All right, excellent. Okay, so about 5 more seconds and we'll close the poll. Go ahead and close that. Okay, so that's really great to get a sense of where people are coming from. And so as we talk today, we'll be thinking about strategies that are appropriate to those settings. So let's talk about why is this important? Why are we talking about our patients with complex needs? We come from different settings. We have different workflows. We have different staff. But I'm going to argue that, number one, we share these patients across our settings. And number two, these patients are challenging. They are the patients we see most in our settings, and they may use the most resources. And an environment that is increasingly asking us to have good outcomes with the most efficient number of resources applied, this group, we need new skills and strategies. So the Agency for Healthcare Research and Quality Medical Expenditure Panel Survey, this is data from 2010, surveyed in household settings, people not in skilled facilities and not military, but looked at who has chronic conditions. And you guys can see here that over 50% of American adults have chronic conditions. Additionally, you can see that there's a high percent of folks with more than 2, okay? And this was data from 2010. This was published in 2014, so likely there'll be an update coming, but I would guess that the number of people with multiple chronic conditions will shift to the right. Why is this important? Because people with multiple chronic conditions, over 2 conditions, these are the folks that are seeing us in our settings. They're seeing us in our pharmacies, they're seeing in our home health settings, and our inpatient stays. Again, these are the people that we all share. Why else is this important? This is a slide talking about payment reform. The Medicare Access and CHIP Reauthorization Act of 2015 that most of us are aware of has already started, you can see in the right lower corner, it's already started to reimburse us that take care of CMS patients on value. VBP is value-based payment. So we're already seeing interest in better quality outcomes and lower utilization compared to our peers in our regions. And when 2019 comes, we'll have MIPS adjustments. And I'll go through that in just a second. But MIPS is going to come on. You're going to want to be ready for it way before 2019 when those adjustments will already be occurring. MIPS is the merit-based incentive payment system that CMS has in stock for us. And you'll notice here that 30% of our reimbursement will be based on our quality outcomes for all of our patients and our resource use. So over 50% of our incentives or our pay will be dependent on our ability to get good outcomes with good use of resources. And imagine, who are we taking care of a lot of the time is patients with complex needs. This is why this is important. And this is just a slide again from the medical expenditure panel showing the healthcare spending. 75% of our money at the 2010 rates, probably more now, is for people with 2 or more chronic conditions. So you can see why this population is important to us. Okay, so we're from different settings. We've talked about why this is important. Okay, how are we doing identifying the patients? How are we doing in engaging our communities to support us? And what are some strategies that have been published in the literature that are going to help us do a better job with our patients? So let's first talk about identification. I'm going to ask people to chat in. How does your organization identify your highest risk or need patients? So how do you do that now? And it's okay if the answer is I don't know. All right, so Brandon says claims-based data. Risk stratification, excellent. Okay, hot spotting. Okay. LACE scores, referrals, ED frequency, readmissions, risk stratification tools, excellent. Based on 2 or more chronic conditions for an H&P, excellent. Okay, so the folks at least that are typing in the chat are already identifying some key ways that we can identify our patients. And for those of you that may not yet be doing that, just look around. There's folks that are doing it in your communities, and let's talk about some strategies that can work. Again, our design today is to address multiple different organizations or types of care situations. So the list that I give may not apply to everybody, but maybe you'll learn something new as we go through. All right. So I would argue that there are 3 times when you're going to identify these patients. One is prospectively, ahead of time. One is at the time that they present in care. And the third is going to be after the fact when they've already had a complex identification or a hospitalization, and they're going to come to your attention. So in the prospective realm, we have registries, okay? And this is speaking a lot to folks that do outpatient care. Meaningful Use and electronic health records have registries. They often will look at particular chronic diseases, or a clinic can pick their own set of codes that they would like to have tracked. There could be a lab value, a medication that's high risk. So there are ways to track patients with your electronic health record registries. Number 2, I would argue, looking a little bit outside of our typical medical world, is there may be patients that qualify for other programs. So it may be a Medicare, Medicaid list or beneficiary list that you're taking care of. Or maybe you're partnering with a human services organization. Maybe there are folks on their lists that you're going to want to address as your patients as a high-risk population. So consider looking not just at your own internal data, but outside. Many of you have talked about claims, payer reports. These are going to be very valuable for you. Payers have all the information about claims that indicate what care people have gotten or not gotten. So those can be valuable. And if you're not getting them, you may want to ask for them. And ask for them in ways that help you identify your complex patients. If your state is lucky enough to have an all-payer claims database that allows for reports for physician offices or care centers or hospitals, you may be getting a sense as well of areas of all your patients that are of concern and hotspot with that all-payer claims database data. Most of us are getting our Medicare Quality and Resource Use Reports, the QRURs. This is Medicare's version of a utilization and quality report. If you see that you're scoring below the community benchmarks on those areas, dig in, look for what's happening with those areas. Yes, the data might not yet be perfect, but it may give us clues of places that we need to look for high-risk patients. And then again, if you're in a care contract that has total cost of care reports, this may, again, give you areas where you're spending more money than average in your community. It might have you target your emergency department utilization or a particular set of patients. So again, don't hesitate to be asking for augmented claims information to prospectively identify folks that you need to know about. They may or may not be on your radar. I want to argue we also have the opportunity just in time. We have acute visits where we see a sudden worsening of condition. And if we have organized our care around those patients, we may be able to support them properly, improve their status, and have them not lead to higher levels of care such as hospitalization or need for intervention. We also have screening visits. Medicare is now paying for the annual wellness visit for beneficiaries. This is a very comprehensive visit that looks for not just medical conditions, but other potential risks in the social area where patients could be then flagged as a complex or high-risk patient. You may not know before you've done that screen, and we're paying augmented amounts to do those visits. You could also just design your preventive visits with an augmented scope if you see an area you want to know more about. PHQ-9 for depression screening, or fall risk screening, or pharmacy screens for complex medication regimens. You can add things to your visit that highlight areas that you're concerned about, and again, identify patients that are at risk. I would also have you pay attention to the no-show patient. In the clinical setting, if a patient doesn't come for a visit, if a patient doesn't attend an important specialty visit you have organized for them, or if they no-show to the pharmacy to pick up chronic medications they should be taking, those are people that you may want to intervene with just in time, identify and support as a more complex patient. And then there's the already in your lap. Many of us have the opportunity for admission, discharge, transfer messaging from our acute care settings. You find out that that person has already been admitted or that they're coming home. You may look, and some of you are, at readmission data. So if you're in a care facility, maybe screening through your patients that are, yes, already complex, but there may be something you're missing in complexity that's leading to readmissions with certain people. Discharge planning data. If you're in a hospital setting, there may be nuggets in your discharge planning or delayed discharges, or with your social work teams. You may identify areas that are important to you. And then obviously post-discharge, when a patient comes to you and has had an acute event, how do you keep them safe in the community with what they need? I saw this in the chat. People are asking their staff and providers. They are key sources for patients that are high risk. I was looking at how do I identify a complex patient, and the AAFP recently published a piece that there's researchers asking providers, how do you know who a complex patient is? And we know that they're going to be people who have chronic illnesses, multiple illnesses. They may have an atypical reaction to the typical treatments that we use for an illness. There was one person that said people who are resilient and fragile may be a complex patient. So they're the ones that don't fit the typical care plans maybe and need extra support. Your providers and staff are going to know who those people are. Okay. I want to just mention, because I think this is a good story to tell. This is from Denver Health, an article published in Health Affairs, and the quotation is there. We will provide these slides if you'd like to check the reference. Dr. McKenzie wrote an article about they spent time looking at their length of stays in a very urban, complicated inpatient, outpatient health system, Denver Health. And they came up with a complex discharge panel, a multidisciplinary group that included administration that looked at what was it that was keeping patients from good disposition and safe disposition. And I'll just want to read a quote from Dr. McKenzie, and then we'll look at this list of things the hospital is dealing with. And he said, we've learned several important lessons from our 3-year journey. First, having senior executives at the table to discuss individual cases accelerates interventions. Second, building relationships with external stakeholders such as other area hospitals, state and local governments, U.S. consulates, long-term care facilities, lowers barriers to coordinated solutions. And third, understanding a patient's sociocultural perspective and family support structure early in the hospital stay helps the staff anticipate barriers to discharge. So this hospital system took on really studying their patients and their complex needs. And you'll see that barriers to safe disposition don't fall just into the medical realm. We're talking about legal issues, financial issues, behavior management issues, capacity for medical management at the next level of care, so a complicated discharge and making sure that happens. And then inter-hospital and international relations and transfers. So my guess is, before they really took on looking at this, they may not have known issues for their complex patients, and they may not have had the same list of contacts and resources to coordinate those patients, but taking that deep dive made a really big difference. Okay. So, identification action. Many of you are already way on top of this. I think we've seen chat from tens of folks here. We're going to want to encourage you to begin or continue to develop your internal systems to scan for populations and individuals that would need supportive care. So my charge for you is to go back to your teams and say, what are we doing now? Are we doing enough? Is there something deeper that we need to do, like Denver Hospital did, to really identify some concerns that we have? And Jennifer Wright just commenting that connecting people to community resources is really important, and we appreciate that. And all of us know that we could do better, and our community partners know that as well. So one action for you today is to begin or develop those scanning systems. Okay, so Jennifer, you're going to like this next topic, assessing our environment for support. So, you know, we saw Denver Health. They were reaching out even to international support for their patients. They put a team together that had high-level administrative as well as their staff. We see in our own environments that we're doing this, but are we doing it enough? So my next question for you in a poll is, do you have designated staff that meet with community agencies on regular intervals to assess for supports for patients? And again, I anticipate a wide variety. My belief is that when we have staff paid to do this work and to align, that means it's important to us and that we put value and stake into that. So I see lots of you do have that. And I'll let you define regular intervals. Okay, so the majority of people answering the poll, all right, have designated staff. Okay, some of you don't yet. Okay, I'll let this go for about 10 more seconds. Okay, very good. All right, so bring in 2/3, 1/3, good. So you guys are already maybe ahead of the game on some of the things I'll talk about, but maybe we'll give you some tools to dive a little bit deeper. All right. So this is a slide, again, from AHRQ, the Agency for, I just forgot, Research and Healthcare Quality, put together a study on the medical neighborhood. In the medical neighborhood, every single one of us falls into this medical neighborhood. We are patients. We are part of communities. We are patient-centered medical homes. We may be in that acute or post-acute group. We may be the specialists or the proceduralists in ambulatory care. We're the pharmacies. We're the labs and the imaging folks. And I want to ask, you know, as you look at where the patient sits, how well are you linking with your state and local public health organizations and your community and social services? And if you are linking with them, are you linking with all of the ones that you need to link with? Just for folks to think about that as we go forward. I want to say that Health Insight is linked well in with state and local agencies and community and social services because so much of our work is collaborative. If you feel like you need resources or ideas in these particular areas and you're not sure where to start, I would highly recommend talking with Health Insight about the partners that they work with. So if you're starting to look at this, or maybe this will help you look at it in a different way, I want us to think about assessing in a systematic way what we're doing with our community. So first, we've looked at what are our most common challenges facing our patient population. And our registries might find those. And our partnerships with other agencies may find some of those. But as those issues emerge, again, I'll go back to the Denver Health list, as you find that, hey, there's a significant portion of your population that has legal barriers to being successful with their health, then what do you do? Who works in the area in the community, and how do you scan? And if you do find an agency you want to work with, who will investigate the best way to refer your patients? Who will be the point of contact? I like to talk about the backline number. Who's the backline number that you're going to get in touch with? And who will ensure that consents to share are in place if you share patients? How will you educate your staff and providers on the services that you make the linkages to and have those referral processes be smooth? And then, after you've linked with an organization, when will you reassess the relationship and the success there and make sure that your organization is getting the outcomes that you want for your patient? So I'll challenge folks that are already doing this to make sure they have these steps in place. Folks who've not yet started, maybe go back to your teams and start to talk about this. You know, where are gaps that we have not yet filled, and how do we make those linkages? These are some tools and resources for assessments. I tried to make them medically oriented And I think they're good examples, again, if you're just getting started or if you'd like to take a more formal, deeper dive. Formal asset mapping is something that public health is very familiar with in their communities. And this is from a link from Washington State, has a medical home set of tools, and they've done formal asset mapping as part of their medical home. I think it's a good toolkit to review. There may be some things that you can adapt in your setting. For outreach processes, a toolkit for collaborative ways of care was put together a number of years ago, but I think is very relevant. It teaches us how to outreach to organizations that we want to work with, make it efficient, make it effective, answer the questions that our providers and our patients are going to want answered, and then develop systems. So I think that's a good toolkit to review if you want to develop yourself in that area. The medical neighborhood assessment from the AHRQ that I showed the slide from earlier is very comprehensive. It's designed for people with medical homes to look outside their four walls and say, what do I need to do to have strong relationships with my referral partners, not just specialty care, but also community care. And I think it's a very robust, valid tool for that setting. And then if you're not aware of it, you should be. What are community benefit opportunities in your area? So nonprofit hospitals in your city and in your communities are required to partner with community agencies to most benefit the patient populations in their regions. The Catholic Hospitals Association of America link gives an overview of what those hospitals do in different regions, and there's a CDC description of how to actively use your community benefit process to make linkages and partners. I'm going to say if you aren't aware of the community benefit activities happening with the hospitals in your area, link up with those. You might want to get in on their process as they're developing their scans. You may want to be a beneficiary of their services, but this is a place where potentially funding or partnerships could be quite powerful. This is just an example of a referral form from the toolkit from Iowa. This is actually a referral template to a community agency. This is something you could adapt. Most of us in the primary care setting are used to referral forms. We put what important information about the patient, we put what we need to get from that patient, from that organization or that specialist. This is a corollary to a community agency. Just imagine if you could have this process be HIPAA compliant, appropriately organized, and slick with a community agency that you work with regularly. Wouldn't that make a difference in your patients getting services? This is a sample referral process that came from the Washington tool. They did a community needs assessment. They found that a better communication tool was needed for primary care and for parents for kids with health or developmental concerns. If I was a provider and I was busy and I could delegate my staff to go look at this website that told me exactly the agency to contact when I had a concern of a child birth to 3 years of age for a specialty care outside my walls, I would love to use this tool. And this is something was put together with a typical population, a specific population in mind, wrangling those websites and things into an algorithm that could be used easily. So this is just an example of something that could be used in your organization, and again is shared in the needs assessment toolkit. All right. So assessment action. I want you to consider how your organization strategically aligns with important community partners, and consider developing a plan for outreach and formalizing important referral processes. I just want to give a quick example that has come to mind for me as I was preparing this talk, is the Qualified Service Organization Agreement. So we know that sometimes it's difficult to share patient information, but with proper business associate agreements, or in the case of behavioral health, a Qualified Service Organizational Agreement, we can have the proper consent process, the proper HIPAA compliant referral back and forth between behavioral health and physical health be developed, so that if you're regularly working with an agency, you guys can share information safely with proper consent in place and remove some of the barriers to sharing that can occur, that are perceived to occur. So that's just one example, for example, of a plan for outreach and formalizing referral process that might be really relevant in your area. Okay. And I just want to just say thank you for the chat and for my partner Wyatt Packer that is addressing the chat as we talk. There's some interesting things being shared. Okay, let's go to strategies. So I want to move now to strategies. Again, my job is to look at things that can be done in different kinds of settings, given that you are all from different kinds of care settings. And I wanted to share things that are evidence-based. Some of them are low cost, some of them are going to be more complex and integrated, but I want to give you some ideas and things and places to look so that you can have creative ideas for your setting. So strategies for managing complex patients. There's a lot of information coming out now about these patients. We've had some good published studies, and these are the best practices that have come out to date. You may have some of your own from your own setting, but I'll share now from a comprehensive review that was done by the Commonwealth Fund, and I'll give you that link and tool because I think it's a very rich, fairly accessible short document that highlights good practices in the community. So first, we want to focus on a high-risk population for your setting, as talked about before. That could be a dually eligible population. Older adults may be the best ones in your setting. People at risk for readmission or emergency department overutilizers. You've all reported that or some of you have reported that you can get that data. I want you to note, look for who will reimburse you initially to do this work. So if you're doing something that's new or innovative, or you're changing a role or adding a staff role, maybe partner with someone who's interested in really good outcomes here, and that can support the financing of that new role. And then you want to design systems that support coordinated care. Again, you want to assess the need or reassess the role for care coordinators or managers. It could be a key player in this complex patient management system. You want to strengthen partnerships between and closed-loop referral with key clinical services. Can't iterate that enough. We want to develop common care plans and communication flow and reduce barriers to the important communication and do it appropriately with HIPAA appropriateness. And then develop systems to rapidly address changes in condition. Okay, that is the best practice. This is just kind of a repeat of some of this, but I want folks to realize these are the elements of the most successful complex care programs for elderly, and that's going to apply to a number of the chronic populations that we take care of. So again, targeting the right people, comprehensively assessing them, finding them in the most appropriate way, evidence-based care planning for their particular problem, and monitoring them ongoing. A number of you have reported you're doing that already. Patient and family engagement, can't say more about that. Coordination of care, facilitating transitions, and then appropriate care in accordance with their goals and priorities. You know, we know that if we give too much care, patients don't accept it well, or it's wasted, and if we don't give enough care, people will go seek it elsewhere. So expand the team, use HIT, implement screening, engage your patients, and we'll just touch on finding financial support to do some of this. Okay, so expanding the team. When we say expand the team, we don't necessarily mean add a person. We may mean more training for particular people that are already successful in their roles. So care coordinators, we have seen success in having medical assistants that are really at the top of their license or the top of their game with extra training could facilitate care coordination in an outpatient setting. Care managers can be invaluable members of teams and embedded in primary care settings, hospital settings, home health, or hospital setting, skilled nursing facility settings. Community health workers, often coming from communities where they are bicultural, bilingual, and they understand the system. Those can be great people to add to your team, that they deal more with what's happening with social determinants potentially, and they can be important communication agents for your system. Diabetes educators and dietitians, how do you harness these richly trained members of our community to better serve your patients and work on self-management and monitoring? Clinical pharmacists, again, excellent with self-management, excellent with preventing safety issues with medications, could be key players in transition and discharge. Home health services, these are, again, important partners that provide things in places and uncover things that we can't, again, in our four-wall delivery service areas. Co-locating your behavioral health providers, having behavioral health providers elbow to elbow with your care teams and communicating on a regular basis can significantly improve the management of chronic medical conditions. And peer support, where is that appropriate? We're not saying that everybody has to hire more people. It may be that for small practices, sharing expanded care team members across practice is appropriate. Or like I said, retraining internal folks to have new roles and new priorities as they work on their day. So now I'm just going to give some examples. So expanding the care team. I don't know how many of you have heard of the IMPACT project, but it has been successful and adapted in multiple settings. They used a team approach, and one of the unique members of their team is a depression care manager. In addition to primary care, consulting psychiatrist, the patient and their family, and a medical assistant. They focus on patient education, on what's supposed to happen as they go through the course of their depression illness, helping them know about self-care, helping them be advocates as they're getting care. They do evidence-based outcomes tracking using the Patient Health Questionnaire 9, knowing that people not just are screened, but that they're in remission at 6 and 12 months. And then there's a care manager and patient that make a relapse prevention plan, because we know depression can be recurrent, and especially in people with chronic disease as they face new advancement in their condition. Results are compelling. In a randomized control trial in older adults with major depressive disorder and dysthymia, they saw 50% or greater reduction in depressive symptoms. That's important. And they saw a decrease in cost over time. Okay, it's not a huge win initially, but maybe making that investment over time over a large population would save a lot of money. And like I said, this model has been successfully adapted for cancer, adolescent, and chronic populations. So I'm going to encourage folks to look at that. If you're interested in behavioral health screening, substance abuse screening, Health Insight is working on that actively in our contracts and populations, and would love to be your ally in having something like an impact program make a difference in your setting. Okay, screening processes. We've talked about them a little bit, but what do you need to do to develop tools that assess key patients for behavioral and social needs, financial barriers, functional status, maybe their activation to take care of themselves, and health literacy. We know that only 12% of adults have adequate health literacy, and for complex adults, it's even probably a lower percent. I want to mention that federally qualified health centers have the PREPARE tool they've been studying as a comprehensive assessment of both social, financial, legal barriers in patients, and it's a screening tool they're going to be using in their settings. Take a look for that, PRAPARE. I want to have folks, again, harness the wellness visit as an opportunity to augment your screening using that structure. Consider in-home health assessments for certain patients, partnering with your home health or with outreach folks to do in-home. And then face-to-face relationship building. We're not talking about this on the phone. We're talking about getting those relationships stable with a care team that patients then disclose maybe some of their barriers to care. So an example is the GRACE program. I want to just mention it because it was targeted to low-income seniors and seniors at significantly high risk for admission. Okay, this is a fairly developed care team doing comprehensive in-home assessment, providing a multidisciplinary team with social work, focusing on patient education at the level of the patient and in different languages on self-care and management. And with this multidisciplinary team, with those high-risk patients that needed that extra resource and care, they were able to see lower emergency department use, hospital use. It was cost-effective after the investment went on over time, and it's noted to be fee-for-service model adaptable. So something that you want to consider in your setting or partnering with folks, check out the GRACE program. We don't want to forget about technology. It's everywhere, but where can it be most effective? I'm just going to say just 24/7 phone lines using technology to connect to call centers or ways for patients to access the right care could enhance your after-hours coverage, especially when people have access to medical records or to care managers or staff that know them. It could prevent significant use of ED or hospital after hours. We have emerging telehealth technology for both face-to-face care and remote monitoring of patients. In my low resource setting, I have had patients even with very low functional literacy be able to use remote monitoring to have a coach at the other end as they manage their diabetes and hypertension and increase their knowledge because they're doing their own statistics at home, and then they're talking to someone about them and making care adjustments right at the right time. Enhanced self-monitoring and reporting from apps or portals. How much are you using that in your setting? How much are you trying that with people that may adapt, and it may become an excellent way to communicate? I know for me, my Medicare beneficiaries are some of my biggest portal users, and they keep me abreast of their specialty appointments and their testing and when things aren't going well. The ADT messaging we've already talked about, and I've seen some interest in the chats. Maybe there's a way to find out at real time when your patients are hitting the ED hospital. You may get information when they're across town in a setting that you're not typically getting information from. So look into ADT messaging with your health information exchange or with your hospital partners. And then finally, clinical decision supports that remind you for recall. We know patients do best when they're regularly checked on, even when their condition is stable, so that we don't miss an opportunity to intervene when things decline. The CareMore project in Anthem used specific remote monitoring. So of course they have that comprehensive initial visit to see what the patient needs. Then using disease-specific care plans, again, picking areas that are high risk for readmission or decompensation, using remote monitoring where the patients are communicating in with immediate transmit to the care team so they can intervene at the right time. Additionally, social and transportation supports, recognizing this is not just about, again, the doctor visit, but there may be other needs that the patients have. And with Medicare Advantage clients and frail elders, again, they saw some outcomes that we think are important in this current environment. This is being implemented in the Medicaid population, and at the time of the report that I read, they haven't seen the outcomes yet to see if it is as effective. Again, many of you have mentioned patient engagement, actively working to develop skill with cultural competency in your setting. Teach back, a simple, cheap way to ensure that patients understand their instructions. Motivational interviewing that can be trained throughout your staff to improve their ability to deal with patients as they deal with chronic illness. Patient and family goal assessment, assessment for financial barriers to care, delivery or referral to patient self-management. So this is a huge plug for teaching patients and families to communicate with you and appropriately navigate the healthcare system. This is a very low-cost intervention that can be activated in any setting. I want to just highlight the example here of the Chronic Disease Self-Management Program, the CDSMP, peer-led in the community. Patients get real-time skill with goal setting in a supportive environment. It's a 6-week class that can be done just about anywhere that you can gather folks with a peer leader, and it has been adapted to other cultures and languages. You can see here the outcomes that we want, which is people being in their homes more, being well. They also have the experience of better self-reported health, and that lasted after 2 years after taking the program. The CDC and CMS have put a big push on getting this out into the community because it's been shown to work so well. And Health Insight is partnering with our communities to train more leaders in this, to have this available in multiple settings. So if you're particularly interested, please reach out to Health Insight. We'll connect you to the right folks. And if you're interested in the program, there's a link here. And there's upward of 13 languages now, I believe, that are, the manuals are available. So if you can get a peer leader in that language, you can have a chronic disease self-management program in your community. So this is a really good intervention to take a look. All right, we're almost to the end. I don't want to forget that we have to pay for these changes in care. And I see that some of you are part of MCOs or ACOs, and you're probably already thinking about how do we stretch our dollars to make the care work for our patients. But I want to highlight a few things. We want to optimize opportunities in our right now fee-for-service codes. So the list that you see here, these are fee-for-service codes, CPT codes, that do have Medicare reimbursement. And on the next slide, I'll show you the averages that you could be reimbursed. So there are places where Medicare is saying, yes, I want to pay you to monitor that patient, not at face-to-face, but in a management way, every month to make sure they stay healthy. Or we want to make sure that they get the annual wellness visit each year to screen for potential illnesses and to prevent decompensation of chronic disease. Shared savings contracts, many of you may have them. There are increasing models for total cost to care-based intervention. So you get to take care of your patients in a way that maximally benefits them and reinvest those savings into the kind of social support or home care or care coordination that makes the biggest difference for the right patients. We want to say that avoiding penalties is going to be good for your compensation. So as the QR/UR reports come out, paying attention to them, learning how to read them, learning how you can impact them each year. And then accountable care organizations, I know in my community, are some of the most innovative groups that are choosing to be accountable care organizations, doing things a little bit differently to get those really great partnerships and outcomes that they want because they have a different payment model that's looking for their outcomes, not just their delivery. This is a short list. I want to give you the caveat that billing for these codes can be complex. You need to be careful with your documentation and that you have the right level of staff. But I want you to be aware of the different places that you can be reimbursed. For example, chronic care management is appropriate for office setting. We have seen some folks use it in assisted living centers or potentially in skilled nursing if there are, again, the appropriate documentation and relationships. On the bottom, highlight the annual wellness visits. We want to see those happen based on the data we have in our Health Insight CMS data. We are not using these as much as we could in our organizations to really take care of our elders and screen for potential issues. So just some thoughts here on the fee-for-service codes that you could engage to improve some of these areas. And we plan to do more education on this in focused areas such as cardiovascular care and diabetes upcoming, and for outpatient providers, the transition of care and chronic care management coding. If you're interested, do let us know if you'd like to be part of those. So in summary, complex patients are important targets for augmented care. Evidence-based programs can improve outcomes and reduce costs. Assess your community to augment resources and develop streamlined partnerships, and then develop billing and coding strategies that help pay for new roles and staff and maximize alternative payment reimbursement. So that's been our very high-level review, and we plan over the next year for a deeper dive into a number of these topics. And we'd love your feedback. If you want to absolutely hear more about something, please put that into the chat, or again, email me with your questions. We have a few minutes left. Let's see. Okay, we have an action chat. So after this 45 minutes of me rattling on, I want you guys to let me know, what are some areas you heard today that you can go to work on in your organization? Or what's an area that you just heard something a little bit different? Maybe you're already doing it, but you heard something different. What can you work on in the next 2 weeks in your organization? Okay, Susan Stoll is going to work on referral forms. I like that. Thank you, Melody. All right, some more thank yous. I appreciate the thank yous, and I'm very interested in your action. All right, formalizing chronic care management patients, excellent. And Kelly, I have resources for that if you're interested. Discharge follow-up forms for community resources, excellent. Okay. Okay, yes, just in time, catching a change of condition, very good. Putting things in place there. We're going to look for a couple more. Let's see. Oh, they're going by so fast. All right, tracking down. Oh, thank you, Kim. All right, tracking down assessments, home assessments, good. All right, appropriate code status, very good. All right, before swift discharges, there was hospitals. Okay, good. So maybe reinstituting follow-up calls if that makes sense. Okay, all right. So there's some areas that folks, so what I can see is there are areas to take action. There are populations that you are developing a new concern about. Again, don't forget those creative ideas that popped into your head. Take them back to your team and very, very much think about that. And think about, who you're going to reach out to. Health Insight, again, works with many community agencies. And if you're at a block, reach out and contact us and let us link you up with some of the folks that we know about. Excellent. Thank you for all the typing and the interest. I want folks to know about upcoming change agent events. So we have a cardiac care webinar coming up around health coaching. We're going to talk about panel management processes, tracking patients with complex needs, and another topic on HIT. Okay, so look for registrations for these. If you're not yet on our list, make sure you get there. And like I said, please reach out to me, Sarah Woolsey. Here is my phone and email address with questions that weren't addressed today. Or if you know that you want to hear more, please chat it in, or please contact us, and we'll make sure that staff at Health Insight gets back to you with your answers. All right, I'm going to go ahead and ask now that Kim launch our evaluation. We wanted to build in time for the last bit of chat going by, as well as having folks do the evaluation, because we do want to hear. Okay, so we got a couple of emails. We'll get those tracked, I promise. All right. So I'm going to go ahead now. We're going to end the meeting a couple of minutes early to give you time to do our evaluation. And when I switch over, then we'll go off. So I'm going to go ahead and wait, a couple more things coming through on chat. See if there's anything left. Let's see. Just before we go off, I want to make sure the last bit of chat gets addressed. And I think you all are typing so much that it's overwhelming my chat box. Okay, excellent. Excellent. I'm going to let Wyatt and Dana make sure we got all our housekeeping done. Excellent. Thank you, Wyatt. Keep connected through us through the Health Insight Change Agents link and our upcoming events. All right. So with that, oh, one more. While they're typing, I would just want to give a shout out to my partners at all 4 states who've been working to help me develop this webinar. Just really, really thank you for all your support, specifically Joan Gallegos, Tracy Carver, and my partner here in the room, Kim Dunn. Thank you so much for your support, and for Wyatt Packer for his leadership. And we'll go ahead and go to the evaluation. Please fill that out for us. We give you 5 minutes at the end of the meeting, and we'll look forward to talking to you in the next upcoming months. Thank you.